Okay, thank you for the opportunity to present our work. We have no relevant disclosures. Gastroesophageal reflux disease, or GERD, is the most common indication for upper endoscopy, or EGD, in the US. EGD utilization, as we know, has increased significantly over the past years. And some of the indications for patients with GERD to get an EGD would be symptoms of odynophagia, dysphagia, those that are non-responders to medical therapy, those at risk for Barrett's esophagus, and importantly for us, those that are pre-anti-reflux surgery. EGD reports are vital for the communication with other healthcare providers, as well as to document the patient's baseline status. Often surgeons rely upon EGD reports to formulate care plans. In an effort to improve performance and documentation, endoscopy standards have been put forth. However, there's been little improvement despite these guidelines. So our aim was to evaluate the clinical practice, how often an EGD report from a referring physician provided sufficient information to understand the severity of a patient's reflux disease and the anatomic abnormalities seen on endoscopy. We performed a retrospective chart review of consecutive patients referred to our center. Patients were included if their chart had a referring endoscopy report. Importantly, to avoid multiple reports from an endoscopist, only the first encounter from an individual endoscopist was used. So we were left with 100 different patients with 100 different endoscopists. The majority of those reported making it to the duodenum, 82% documented retroflex view, 65% the location of the squamocolumnar junction, and 52% documented the location of the gastroesophageal junction. In our series, only one person, our endoscopist, reported Hill grade on retroflex. We had 33 reports of esophagitis, 15% using the words erosive in their description, but only 42% actually used validated grading criteria using the LA or the savory grading criteria. Importantly, pH testing in 18 of these 33 patients showed that there's actually normal acid exposure in 7, which may indicate that using a generic term of esophagitis may not actually be adequate to provide documentation of abnormal esophageal acid exposure. We found that 28 patients were reported to have columnar-lined esophagus, with the length reported in just over half. However, no report used the validated PROG classification or provided sufficient information within the report to be able to determine it. Many of the referred patients had a hiatal hernia with size documented in half, and the rest just subjectively documented the hernia. The type of hernia, sliding versus paraesophageal hernia, was classified in only 26%, which may be problematic for patients with a paraesophageal hernia, especially if acute symptoms develop, as patients are unaware of their anatomy and other healthcare providers have insignificant information. We found that one or more biopsies were performed in the majority of patients. However, when we looked at the number of biopsies from a location being reported, only 22% actually reported the number of biopsies. 12 patients did have an EGD with an indication documented for Barrett's esophagus surveillance, and of those, a Seattle biopsy protocol was used in only 3, 25%. It's clear from our results that EGD reporting is far from standardized. So at our institution, we've proposed a template using 3 landmarks and 3 descriptors. The 3 landmarks, documented in centimeters from the incisors, include the squamocolumnar junction and the gastroesophageal junction, with the difference defining the length of the CLE, and then documenting the crural pinch with the difference between the gastroesophageal junction would define the size of the hiatal hernia. The 3 descriptors, with additionals as necessary, would include the appearance of the squamocolumnar junction, such as normal, regular, or using that PROG classification. We also think that using mucosal integrity is important, especially if esophagitis is present, and using a validated grading system. Also, using hill grade is important when you do the retroflex view of the cardia. So in conclusion, the infrequent use of grades for esophagitis and columnar-lined esophagus can lead to poor communication of a patient's baseline reflux disease. The lack of adherence of Barrett's esophagus surveillance biopsy protocols and documentation of hernia size and type can impact patient care and potentially outcomes. Therefore, we propose using a consistent reporting system that would include 3 critical landmarks and 3 descriptors, which may go a long way towards improving EGD reporting standardization. Thank you.
Well done.